Hello. Okay, so the question is angiotensin 2 maintaining GFR. So let's go to this one here. So we're talking about angiotensinogen constricts the efferent side of the arterioles. So if you had to get somewhere, you got traffic, and the traffic is on the efferent side, you can't leave wherever you're going, so you're stuck where you are. Because you're stuck where you are, think of it as blood. Blood's going to get stuck in the glomerulus, which is right here in the middle. So on the efferent side, because that's where angiotensin 2 has its effect, if we constrict it, which is what norepinephrine is going to do normally, we have normal blood flow coming in from the afferent side. Everything is good on that side, but we constrict the efferent side. You're going to get a buildup of hydrostatic pressure. Therefore, if you have an increase in hydrostatic pressure, that's forces that are favoring filtration, and that is going to cause your GFR to go up. So, Gabriel, I hope that answered your question. Determinants of GFR. Okay, so when we talk about GFR, everyone gets confused on these factors that favor filtration. So when we're talking about forces in regarding like Frank Starling's forces, we have oncotic pressure, we have hydrostatic pressure. We talked about factors that favor filtration. So things that are going to push it into the Bowman's capsule, going into the filtrate, into the tubular fluid, and eventually going to make your urine. The first one that's going to favor the movement of fluid out of the blood into the Bowman's capsule is hydrostatic pressure of the glomerular capillary. That's the blood that's coming in. This is going to favor filtration. Also, a hydrostatic pressure of the Bowman's space or the Bowman's capsule. That's going to favor filtration because that should be 0. So the lower that is, it's going to less suck, therefore favoring filtration. Factors that oppose filtration having hydrostatic pressure build up in the Bowman's capsule, because the hydrostatic pressure is the flow from, or it's going to go from high to low. If those gradients start to even out, it's going to oppose filtration. And obviously the hydrostatic pressure of the glomerular capillary is going to oppose filtration. So we know that this should be 0. There should be never any protein in the oncotic. There should be no protein in the Bowman space, so therefore that should be 0. This is the big one right here. The hydrostatic pressure of the glomerular capillary that's going to have the biggest effect on GFR. Hope that answered that question, Gabby. Maria, if K is high, is it only regulated through aldosterone, or does ADH also have regulatory effects on potassium? ADH has nothing to do with potassium. ADH is only free water. That's it, nothing else. Now, aldosterone. Major effect of aldosterone. Increased sodium reabsorption, and we know water is going to go along with it. Increased potassium secretion. It's going to go into the urine. So, one of the rare triggers for aldosterone, besides the RAS system, another way to get aldosterone is by having very, very high potassium. So that would cause, again, through having high aldosterone, is going to cause potassium secretion. Remember, we don't care about the urine. We care about the blood. We need to get that potassium out of the blood, and we got to put it into the urine. So in high concentrations, aldosterone will do it. But don't forget, insulin will also drive K into the cell. So it acts like almost like a buffer for high potassium. Insulin's going to drive it into the cell. Norepinephrine will also drive potassium into a cell. So when you have very high potassiums, these are some of the things that the body's going to do to regulate the potassiums. So Maria, hopefully that answered your question. Gabriel, for the mild constriction, we have an increase in GFR, but extreme, we have a decrease. So with the angiotensin works regardless. And we're just saying that if we cause a very, very strong constriction of the efferent arteriole with extreme constriction, and I will tell you on an exam, it'll be extreme constriction or mild constriction. I won't leave it ambiguous at all. So we have our Bowman's capsule. Here is our afferent, doing just fine, but we're causing some extreme constriction on the efferent side. When this happens with extreme constriction, you get a buildup of hydrostatic pressure in the glomerular capillary. Yes, we understand that. More blood volume there, and it's going to start building up. However, what also starts to happen with this extreme buildup is the proteins start collecting in this space also because they can't get through. They start to build up in this space. So the hydrostatic pressure builds up as well. We know increased oncotic pressure starts to build up as well. Elevated oncotic pressure of the glomerular capillary is going to oppose filtration. So as it starts to build up more and more. Oncotic pressure starts to exert more of an effect. GFR starts to come down. So the reduction in GFR is due to the increased oncotic pressure of the glomerular capillary because the blood gets stuck. It can't get out due to that extreme constriction. And there you have reduction in glomerular filtration rate. So Emma, I think I answered your question there. Okay, so Sarhita regarding GFR and creatinine clearance. With high GFRs, very high numbers, normal healthy kidneys should be at least, do it the other way. Should be greater than 90. As it's greater than 90, we know we can clear things out of our system appropriately, which is what creatinine clearance is. Clearance is what's rendered free from the solid rendered free from the blood in a minute. So we look at creatinine because we know it's a constant production of creatinine because it's a function of our muscle mass. So as we have an adequate GFR, we will have a low creatinine levels in the blood because they're going to be low because we can get rid of it. As the GFR starts to decrease, GFR function decreases, we can't clear things as fast anymore because we're not filtering as much blood as we used to. So because we can't clear everything as fast, things start to build up. So when the GFR starts to decrease, it will lead to an increase in creatinine clearance, creatinine in the blood, creatinine level in blood, put it that way, because the clearance is decreasing. Okay, so Srihita, hopefully that answered yours. Gabriel, do NSAIDs work the same as norepinephrine and the afferent? Yeah, just know that NSAIDs only affect the afferent sides. And on the efferent side, because angiotensin is the angiotensin 2 is the main one. On the efferents, it's angiotensin 2. In order to make angiotensin 2, you need angiotensin 1 to go to angiotensin 2. This is an enzyme, angiotensin converting enzyme. So if we block this enzyme from working, you don't make any angiotensin 2. If you don't have any angiotensin 2 made, there's nothing causing constriction on the efferent side, and you cause dilation of the efferent arteriole. Dilation of the efferent arteriole can reduce renal blood flow, causing reduction in GFR, which in some kidney patients can actually make their kidney failure worse. High blood flow from the afferent to efferent decreases hydrostatic pressure and lowers oncotic pressure. So when you say high blood flow, when you're talking about when you dilate it, you're having a greater amount of flow. And not really lowering oncotic pressure. It decreases hydrostatic pressure, but the oncotic pressure actually increases. And if we go to this picture, okay. Blue line, hydrostatic pressure. Red line, oncotic pressure. Both glomerular capillary. As we start on the afferent side, and we go towards the efferent, hydrostatic pressure starts to decrease a little bit as we go down the capillary. Why? Because we are losing this fluid into the urine. If we're losing fluid into the urine, our volume of urine, the volume of plasma in the blood decreases because we lost some fluid into the urine. Hydrostatic pressure starts to drop. As we lose fluid in the blood, solutes, for instance, proteins, exert a bigger effect because we're losing solvent in the solution. So the proteins, the oncotic pressure starts to increase. Eventually, as you start going along the length of the capillary, the hydrostatic pressures and the oncotic pressures, remember they're opposing filtration and favoring filtration, they even out. So whatever was being pushed into the urine is being brought back and reabsorbed into the bloodstream. So that's why we call it a filtration equilibrium, because the hydrostatic pressure and the oncotic pressures essentially have evened out on both sides of that equation. No net movement of fluid. There is still fluid moving. It's just no net movement, because if 10 milliliters left, 10 milliliters are coming back in. Zero net movement. And that's why we have this filtration equilibrium. So hopefully that answers the question about the high blood flow from afferent to efferent causing that. Splay, don't go crazy about splay. Splay is mainly talking about transport mechanisms. So just know that for like glucose, we will all splay is saying that of the 400, 800,000 nephrons you have in your kidneys, they don't all maximize their transports all at the same time. They start to slow down gradually until you reach a point where you just do it, you stop. That's what the splay is referring to. Just the speed at which these nephrons start to slow down is not a constant, it just slows down. Don't go crazy depth into splay. Just understand that you have only a certain amount of transport mechanisms available to reabsorb something. And once you've maxed that out, you start excreting glucose into the urine because we can't reabsorb it. So this line and this area under this curve should be resembling the area under that line as well, because they're both representing similar things. The ability to reabsorb slows down, and because we can't reabsorb it, it's going to stay in the urine, and glucose concentration in the urine, in the excretion, starts to go up as well. Okay, let's go through diuretics. This is a great slide to look at for diuretics. Okay, sorry. Okay. So, don't worry about this one. That's just osmotic diuresis. I mean, just sodium's leaving, so water will go with it. First section, proximal convoluted tubule, carbonic anhydrase inhibitors. Why do they work here? Because these are the enzymes this is the area of the kidney that has the carbonic anhydrase enzymes. So we know from the pulmonary system, we learned about, remember the equation, water, carbon dioxide, carbonic acid, which then dissociate again with carbonic anhydrase to make hydrogen plus bicarb. These are here, so therefore if you block it, you don't produce water and you just diurese out. But we don't really go through that too much. We went through the loops, the thiazides, and the potassium sparing. Loop diuretics. Loop diuretics work because of the way that the receptors are located in the loop. Remember, in the loop, it is a triple transporter. Sodium, potassium, and chloride. All three have to be bound to this receptor for the reabsorption of sodium and the whole thing to occur, to pull all that out and pull it back into the bloodstream to reabsorb it. When you give a loop diuretic, the loop diuretic blocks chloride from binding to that receptor. And when it can't bind to that receptor, the entire receptor shuts down. All three receptors shut down. It's all done. You can't get sodium back in. So sodium is going to stay in the tubular fluid. And if sodium is staying there, water will stay there as well. Thiazide diuretics. Also, let me change that. Similar. Sodium and chloride channel receptors. Thiazide diuretics, again, block the chloride channel in the distal convoluted tubule. That's the only place that has these type of transporters. So those thiazide diuretics work at the distal convoluted tubule to shut down that entire thing. So all that sodium and essentially the water stays in the tubular fluid, essentially making the urine. The potassium sparing diuretics, late distal convoluted tubule, more in the common collecting duct. This is under, um, this area is under the effect of aldosterone. So when we want to talk about potassium sparing diuretics, what they're doing is they are blocking aldosterone. They are aldosterone antagonists. Remember, with aldosterone, the effect of aldosterone, sodium out, potassium into the urine. That's the role of aldosterone. When we give an aldosterone antagonist like spironolactone, shuts that off, sodium stays in the urine, potassium goes back into the bloodstream or stays in the bloodstream essentially, and you don't have the potassium wasting effects of those. Also, when you notice, look at the distal convoluted tubule and the loop, that's the areas also that has sodium reabsorption. That's why those channels are there. That's why our drugs that we use attack those areas specifically, because that's where the sodium reabsorption occurs. Okay, Maya, during antidiuresis, where is urea reabsorbed? Okay, let's pull up urea here. Calcium, urea, okay. So I'm not, what do you mean by antidiuresis? Do you mean dehydration? Because urea and NADH don't, oh, I see what you're saying. So antidiuresis, remember, so when we reabsorb water, it concentrates the urea because we're pulling water out and the urea stays in. So it creates a diffusion gradient for urea reabsorption into back into the blood. So therefore you have an increased BUN with increased ADH. So therefore, because we know with dehydration, the osmotic gradient, the diffusion gradient is reversed now for urea, and we get urea back into the bloodstream, blood urea nitrogen BUN, so that we use that as a marker of dehydration. Thiazide increasing calcium reabsorption. Okay. Don't worry about that, Emma. Just know that it can increase calcium. Don't go crazy trying to figure that out. Actually, you know what, Emma? I wrote this sort of wrong. Let me go this one. Hang on. Number. No, it's fine. No, you don't. You don't even know about principal and alpha intercalated cells and their effect. So, Fama, I'm not sure I understand your question. So, calcium, one of the three main electrolytes, to be excreted by the kidney, but is reabsorbed in distal. Um, they're where they're reabsorbed doesn't really matter. Just that as long as they get reabsorbed, um, whether it's distal, it's all the same. Okay, Gabby wants to know about high and low effective circulating volumes. Okay. Okay. So, low circulating volume. That's not right. There it is. Hemorrhage, some reason, major dehydration. I don't know why that keeps changing my font, but I'll change it. There's some reason you are losing a tremendous amount of volume of blood. How does our body sense that? We have to get our blood volume up again. So, juxtaglomerular apparatus. Okay, blood volume coming into the glomerulus. We have the macula densa there, and that senses the low blood volume to secrete renin, which activates the entire renin cascade, and aldosterone at the end. Main job for aldosterone, sodium and water retention. If we increase the water that we're reabsorbing, blood volume goes up. So therefore, blood volume goes up, our mean arterial pressure is going to go up. I mean, that's what we want. The other ways that our body senses it, we have low pressure baroreceptors. So in those low pressure baroreceptors, atria has it. Not atria, I'm sorry, aortic arch. Can't remember where they are right now. But low pressure baroreceptors sense it. We have low pressure in the system. Increased ADH secretion, which is going to increase the reabsorption of water, increasing our blood volume. It also causes vasoconstriction through those V1 receptors. If you're squeezing those vessels, pressure is going to go up. Remember, our main goal is to maintain that MAP, get that cardiac output up, get those pressures back up. High pressure baroreceptors, sense those. This is our sympathetic nervous system action. Increase cardiac excitation, increase vasoconstriction, all with the goal to increase mean arterial pressure. So those are the ways. We have those Starling forces here as well, but these are the main ones I want you to know. The RAS system, increased ADH secretion, and our sympathetic nervous system are the big ways that our body is going to respond to low circulating volume. The problem is with high circulating volume, we don't want those things going on. We want to find a way to reduce volume in the blood. We need to get volume off so the heart can work better. Juxtaglomerular apparatus is really do nothing because all it's going to do is just shut off renin. But that is implied because there's no stimulus now, because we have high volume going in. So that won't really do much. Those low pressure baroreceptors are now going to release atrial natriuretic peptide to cause normal natriuresis in the kidneys, renal sodium, and water retention. So it's going to reduce the retention of the water, so we're going to pee it out. Remember, it's natriuresis, so the sodium is going to stay in the urine, in the tubular fluid, drawing water in, and that water is going to come from our blood volume and plasma and reduce it. The high pressure baroreceptors are not going to be firing right now, so there's going to be no sympathetic nervous system firing right now. Therefore, our vessels are going to start to relax. And when they start to relax, we can reduce our pressure when we have high volume situations. And that will help reduce our pressure. So hopefully that answered your question regarding high and low effective circulating volume. Just know with a high effective one, there's too much volume in the system, we have to get rid of it. And way we do it is natriuresis. VIP. Okay. Let's see, where was this one? You know what slide that was on, Maya? Oh, here it is. Okay. I wouldn't go in much detail about this. Make sure you obviously ACH, you know what, and ATP and nitric oxide. Don't go crazy with a vasoactive intestinal peptide. Yeah, the Starling forces are like oncotic pressure and hydrostatic pressure, and knowing that if you have if the forces that favor filtration are strongest, you're going to filter out. If the forces that oppose filtration are stronger, they're going to pull water in. So it's all similar to our normal hydrostatic and oncotic pressure stuff. Okay, so let's talk about potassium and sodium here. So it's really, no, come on, okay. This is what you're referring to. Okay. So when we have diuretic use, we're blocking the whole receptor or the whole protein from transporting sodium out. So before we start this, let's look at this real fast for sodium. Okay. 65 to 75% of sodium is reabsorbed up here. 15 to 20% in the loop of Henle, where the loop diuretics work. 5% in the distal convoluted tubule, where the thiazide diuretics work. So we're still reabsorbing 65 to 75% at first of the filtered sodium into the tubule. Normally, we should be reabsorbing 15 to 20% of it here. Let's say we gave them a loop diuretic. Now we're not going to reabsorb that sodium right here. So all this extra sodium that's floating around stays in the urine because it's not going to get reabsorbed there. Only 5% of it is going to be reabsorbed here. So all this extra sodium that's staying in here gets to this part in the common collecting duct. So that's where this sodium dump is coming from. We've given them a loop diuretic. We're not going to absorb the 15 to 20% here. So all this sodium that should have been reabsorbed right here is not. So it stays inside the tubule and it floats around the urine. Obviously causing that osmotic gradient, so water is going to stay in to the tubule and then we pee it out. So now we know this is where all that extra sodium comes in. Now, let's go talk about potassium and all this extra sodium that's coming through the pipes in the tubules when it gets to the end here. Okay. So, with an increase in sodium delivery to the cortical collecting duct will cause an increased potassium secretion. Why? They inhibit sodium reabsorption upstream from the cortical collecting duct. We just mentioned that in the loop and the distal convoluted tubule are the two major sites for your thiazide and your loop diuretics. So that just drives further potassium secretion, decreasing ECF for your potassium. That's what so that's where you get this potassium wasting diuretics, because they are going to increase the load of sodium going through, and we have that sodium potassium exchanger kind of shuts down and it drives potassium to be brought into the tubular fluid. So Diamond, I hope that answered your question about the potassium with regards to the sodium. My slide 55, I think I skipped those stuff with regards to, it more leads to more like diarrhea and those type of things. So I kind of didn't want to go into much detail about it. Oh yeah, we didn't go crazy into all that stuff, so don't worry about this one. It's not going to be mentioned in your exam with the VIP here. This has to do a lot with like E. coli. It's got to do with other like enterotoxins, travelers diarrhea, that when you go to different countries and eat their food, you're not used to the flora that's there, and it causes GI upset. That's usually what's going on there. You're activating these chloride channels, which just dumps water continuously into the large intestine, and it comes out later in small intestine too. No, the exchangers go in the opposite way because of the increased load of sodium that's coming through. The sodium is going to want to go out, and potassium is going to get dumped into the urine. Okay, atherogenic proteins. So, first of all, let's start here. Lipid metabolism. Liver, synthesize of triglycerides and cholesterol. So it's already making it. The problem is when there's too much of it inside. So the big thing that you gotta know, okay. From the liver, they're making these. These are the atherogenic. These are the ones that when you have tears and damage the lining of your vessels, these are the ones that can get lodged in there, creating foam cells that have to be repaired, and then you get the whole plaque buildup. So these are the ones that start depositing fatty streaks into your vessel walls. You already have them in your aorta when you're in your 20s. So those are atherogenic. They're going to make an atherosclerotic plaque. All the LDLs, IDL, VLDL, these are low density lipoproteins. This is the apolipoprotein, ApoBs. These are just the hats, they're just little targets that will tell the body that these are bad ones. And then you have your anti-atherogenic, the HDL, which is your good cholesterol, high density lipoproteins, reverse cholesterol transport. They're scavengers. They're going to bring cholesterol back to the liver to be put into the bile so that you can get rid of your cholesterol. Okay, let me go back to that one for renal. Dima, I'll get to you in a second, but Catherine, the aldosterone, they do a little bit of similar with sodium, but not that big of an effect. The big thing with aldosterone is to know the RAS system. Let me go back to the renal one. Okay. I'm just trying to get the right slide for the other question. Of sodium going through the whole system has an effect at the common collecting duct with regards to the sodium and potassium exchangers. The potassium and the hydrogen is mainly when you're talking about like acidosis and acid-base balance, how those things cause changes. Renal regulation in terms of ammonia and titratable acids. Just know that we have these titratable acids that when we need to get rid of acidity, we have ways to bind that hydrogen to these titratable acids to get rid of the acidity, and then we just pee the titratable acid out. So they're ones that can accept where is it? Here we are. Okay, so here's the ammonia one. You don't need to know all the stuff inside here. Just know with a titratable acid, we're losing the acid in the lumen is going to go out in the urine. And we're gaining bicarb. So we're titrating out the acidity by dumping the acidity into the urine, and we're able to produce bicarb, which is also going to help reduce the acidity of the blood in that way. We also have titratable acids. One of them is our phosphoric acid. with these phosphate ions. Again, they're just going to be, all these titratable acids, all they do again is just bind to the hydrogen. And they just bind to it, and they're able to hold on to it and be able to pee it out. So we're able to titrate these things and get rid of them. That's why they're called titratable acids. Okay. Kelly, you don't need to know where it happens. Gabby, review the control of micturition? Sure. Okay. Everything you need to know is just in this one. Know that we have visceral afferent innervation, and this is what sends the signals to the brain as far as how big our bladder is getting. So when you have this, the feeling that you have a full bladder, it's because of these nerves sending signals to the brain that we have a full bladder. Then, this is in the micturition center in the pons. Now we're coming down the spinal cord in our efferents that are going to systems. Sympathetic innervation into the urinary system with regards to micturition through the hypogastric nerve is going to stimulate the internal sphincter, constriction. Okay, so obviously we're going to not urinate. Remember, fight or flight, we don't want to stop and urinate because we're running away from something. Internal sphincter clamps down, so we don't go anywhere. That's the sympathetic side. There also is a little bit in the detrusor muscle, but not much. So really, it's the internal sphincter. On the parasympathetic side, it's the pudendal nerve, S3. Oh, that's on the. That's the motor nerve. Parasympathetic innervation, pelvic nerve. Remember, S3, S4, S2, S3, S4 are the main ones for parasympathetic in the sacral division. And what that is going to do is two things, the parasympathetic. So now think about, okay, we're going to the bathroom, we're going to urinate now. Sympathetic system is dominated now by the parasympathetic system. What the parasympathetic system is going to do is going to cause a stimulus of a constriction of the detrusor muscle in the bladder to constrict the bladder, and it's going to inhibit the internal sphincter, so the internal sphincter relaxes, bladder is squeezing, all that fluid is going to go down the urethra, and it's going to hit and meet up with the external sphincter, which is under motor nerve control with the pudendal nerve. And the pudendal nerve, again, somatic, voluntary, is the external sphincter. That's something that you can voluntarily, with your mind, control that to prevent yourself from urinating on yourself. When you go to the bathroom, you relax that sphincter mentally. You just tell yourself to do it, and you go to the bathroom. So that's how we control micturition. With regards to this one, this just tells you these micturition contractions are the stimuli that when obviously our bladder is getting fuller, as those stretch receptors start to pull apart, they send more triggers, goes to the brain, our bladder is getting full, we may have to go to the bathroom. Okay, efferent and afferent in the gut brain. Okay. Okay, if we cut this down the middle, we have sympathetic on one side, we have parasympathetic on the other. The sympathetic efferents that are leaving the central nervous system that are going to cause an inhibition in intestinal motility, which is going to have an effect on the enteric nervous system. The afferents that are leaving the visceral organs will relay pain back up to the brain. So pain is delivered via sympathetic nervous system afferents back to the brain, going towards the brain, afferent back to the brain. Parasympathetic side, stimulation of the parasympathetic from the brain going to the enteric nervous system, intestinal motility, and also stimulates exocrine secretion, we're going to be digesting our food, rest and digest. Makes sense. Intestinal motility, get the stomach moving again. We have to move that food along the conveyor belt, and we have to get secretions going to break down all those food we just ate. The stuff coming from the pancreas. All the things that are secreted in the large intestine, the small intestine. All those things have to be stimulated by the parasympathetic nervous system. Now, when we have enlarged stomach distension, we feel full. Those type of distension, we feel full, we've eaten enough. Those signals are going from the gut via parasympathetic afferents back to the brain to let the brain know, hey, our stomach is distended too much. We ate too much food. We have pain. We're distended right now. We're nausea. Remember, that's the vagus nerve. Our parasympathetics go back. Vagus nerve will do both afferent and efferent. So those things are parasympathetic. Sympathetic is more pain related. For compounds excreted by the liver into the bile, do we have to know specific or just their endogenous? No, like cholesterol. Like what are they made up of? Let me go to bile. Oh, okay. Yeah. The big one is bile salts, lecithin, bilirubin. I mean, they're all there. Cholesterol. Those are the big ones as far as what you got to know what's in the bile. Okay, the crypts of Lieberkuhn. Okay, big things about the crypts. They're all over the entire small intestine. The important thing, they have goblet cells. So remember, whenever you see goblet cells, they're going to make mucus. All this food has to slide across the small intestine. Mucus makes it slide across. When you don't have the mucus, it doesn't slide very well. Also, that protection is there. Enterocytes secrete water and electrolytes. Remember, we have to have sodium and we reabsorb it back in. So if we don't have enough sodium in our food that we're eating, we can add sodium in from are in this area to allow that transport to happen. And obviously, because we know we make like liters of the stuff a day, we reabsorb most of it. Brunner's glands, only in the first few centimeters of the duodenum. Remember, that is the first area that receives the very, very acidic chyme from the stomach. That's why we have alkaline mucus there, because it has to be able to neutralize the acidity. So that's why Brunner's glands are only right there. Lieberkühn's over the whole thing, mucus, electrolytes, water secretion, keeps things moving, protects the lining. Those are the big things really regarding the Krebs of Lieberkühn. Paracrine control, slide 23. Okay. Paracrine control means we have a bunch of cells. This cell is going to release a hormone, and in this case, serotonin, somatostatin, or histamine, that are going to affect the hormone, the cells around it. That's what paracrine control is. So they're all local with each other. It's just they affect the cells right near it. If it was autocrine, then it would affect itself. So we did that a little bit today in endo with regards to like paracrine control and autocrine control. Paracrine is going to affect target cells, but they're very, very, very local to affect target cells. So serotonin, produced by enterochromaffin cells in the mucosa, and it's going to have an effect locally right nearby, intestinal motility and secretion. Same thing with somatostatin. Just remember, somatostatin, D cells inhibitor. Stop. We're going to learn somatostatin again when we talk about growth hormone tomorrow, probably. Histamine, again, a paracrine control. Histamine, when it's released, has a stimulatory effect on acid secretion in the stomach, and it's released by the stomach cells, so it has a control right nearby, and that's why it works so fast. So, Anthony, how do you know what exactly causes an anion gap when looking at values? Keto acid, lactic acid. You really can't unless you draw those labs. That you look at ketones, you look at lactate in the blood, you'll see those going up. But the real way to do that is with the history. What were they doing? Lactic acidosis, were they working out heavily beforehand? Were they running all-out sprints all day and not stopping? That's lactic acidosis. If they had diabetic ketoacidosis, they came in, they were a young kid, 11, 12 years old, lethargic, in a potential coma, that sets the stage. Well, maybe they were, maybe they're type 1 diabetic and they can't make any insulin, so they're in ketosis and they can't handle the acid. So I'm not going to ask you a question like that on your exam, but just for knowledge, it usually comes from the history. If someone said that they tried to commit suicide and they tried to, they drank antifreeze, that will cause an anion gap. But because you know the history, then you know what's causing that anion gap. So that's very important. That's why history is so important. Like mechanism of injury. How did you get hurt? What were you doing? How were you, whatever you're doing. So it's always important to know all those things about your patient. Mechanism of gastric acid secretion. Meaning all of this stuff, all the different hormones and how they do all that, like the gastrin, or are you talking more stomach area? Okay. So what I do want you to know, we know gastric acid is HCl. We know we have to get these out. Where is the chloride coming in from? Chloride shift to get that bicarb out. Where is that hydrogen coming from? Hydrogen is coming from the hydrogen that you get from that carbonic anhydrase. Oh, you're killing me. Then you have that potassium hydrogen pump. And that's where the hydrogen comes out from. And then the hydrogen and the chloride just combine in the stomach and you make your acid. Just understand that chloride is coming in from the chloride shift, the hydrogen from the hydrogen potassium exchanger. This is also why with vomiting causes hypokalemia, because you're losing all this potassium in the vomit and it goes away. Okay, cells of the stomach. Okay. So here is our cells. This is the one you're talking about, Gabby, I'm assuming. Mucus cells, self-evident, we know what those do. Parietal cells. What do parietal cells do? Parietal cells is where we make our hydrochloric acid and intrinsic factor. Remember, intrinsic factor is very important for B12 reabsorption, or absorption, I'm sorry, in the terminal ileum. So, but it's secreted in the stomach. Okay. Chief cells. Chief cells or peptic cells make our pepsinogen. So pepsinogen, remember, is used for protein degradation. Remember, pepsinogen turns into pepsin when the stomach acid decreases. D cells, so is your somatostatin. And they are not really labeled here, but we know that they exist. And actually, they're over here. There's the D cell. And we also have G cells in the antrum, and they produce gastrin. Remember what gastrin does? It goes in the bloodstream, promotes more gastric acid release, and gets our stomach ready for digestion. So there's our G cells. They're in the antrum. They make gastrin, which makes sense because that's pretty much where the blood supplies are going to be. So the gastrin doesn't need to go into the gastric pit. It doesn't need to go into the stomach. Gastrin needs to go into the bloodstream because gastrin's a hormone. Now, here is talking about paracrine control, especially with regards to histamine. Histamine is made from our ECL cells. And pterochromaffin-like cells is where our histamine comes from. Histamine will act on the parietal cell locally, paracrine effect, to increase gastric acid production. So there's your histamine cell. We know the vagus nerve is going to release acetylcholine. It's a parasympathetic nerve. Acetylcholine, again, rest and digest. Stimulatory, make more hydrochloric acid. And what else we got here? Yeah, that's pretty much it. And then we have, obviously, here is the gastrin, which goes into the bloodstream. Gastrin will also hydrochloric acid secretion, histamine secretion, which further increases hydrochloric acid secretion. And these are the D cells, again, stop. This is our somatostatin. So it's going to stop this from happening. It's also going to stop the histamine production. If you stop histamine, you're going to stop, obviously, the gastric acid secretion from histamine. So also, here's your D cell again. Somatostatin turns off your G cells. So somatostatins always stop. It's going to inhibit everything. Okay, so prostaglandins, let's go over that. Okay. Okay. So prostaglandin E2, what it's going to do, the main goal is it's an antagonist of histamine, so it's going to stop histamine from being made. So in a way, by reducing gastric acid secretion, you're protecting the gastric mucosa. Gastric mucosa is under a big balance of your protective benefits and your harmful benefits. Increased acid is a harmful benefit or harmful response to the stomach lining. Your protective benefits is obviously your mucosal barrier. Okay, so those are protective benefits. So prostaglandin is a protective benefit because it's going to block histamine from being made, less acid production. When you take NSAIDs, it's going to inhibit prostaglandin formation, Without this, we have increased gastric acid secretion in the stomach, causing an upset stomach. It can cause gastritis if it stays there for a long period of time. It's not really a drug. We just block the effect of prostaglandin E2, which is going to block histamine from being produced, which is going to block hydrochloric acid from being produced, therefore protective for your stomach. So we like prostaglandins. Also, let me go to this one. Where is this? This is slide 48. Here we are. Prostaglandins maintain the physical chemical barrier by stimulating secretion of mucus bicarb. When you inhibit prostaglandin, again with NSAIDs, you lose your protective barrier, and then the acidic environment is there as well. So that's why we don't like, if you're on chronic NSAID use and you start getting GI upset, it's most likely due to the chronic NSAID use, so we just stop it. Okay, the GI stuff. Let me go. Okay. So the real thing here is that when chloride starts getting dumped into the lumen of the uh, the GI system due to an enterotoxin like E. coli. It turns on these chloride channels. Chloride starts getting dumped like crazy. Because sodium gets through as well, it goes through, we make salt. That creates an osmotic gradient or diuresis or osmotic gradient for water. Water starts pouring into the intestines because of the salt concentration increasing from these chloride channels being dumped on and turned on. So a lot of water goes in, profuse diarrhea when these chloride channels get turned on. Now, when the chloride channels get turned off, like in cystic fibrosis, their chloride channels don't work very well. Because the chloride channels don't work, no water can really flow into the intestines. Less lubrication of water, so patients with cystic fibrosis have severe constipation because these chloride channels don't get turned on. So these enterotoxins, some of them will, through either increased cyclic AMP or increasing calcium inside the cell, will turn on these chloride channels and they start dumping chloride into the intestine. Water is going to follow with it to keep the osmotic gradient going. Diarrhea. So that's where the chloride channels come into play. Okay, 94. Okay. Okay. Let's think about this again from digesting food or not digesting food, parasympathetic versus sympathetic. Parasympathetic, we want to digest our food. So, acetylcholine, we know, is a parasympathetic neurotransmitter. It's going to stimulate enzyme release because we're digesting our food. We need our pancreatic enzymes to be released. Cholecystokinin. This is released by the duodenum when it senses the acidic chyme or distension in the duodenum. If we have food and chyme in that duodenum, that means we need more pancreatic juices because we have food and chyme that needs to be broken down even more. So remember your anatomy. When you have your duodenum coming off the stomach, this is where your sphincter of Oddi is. And that's what connects bile and pancreatic enzymes. In the duodenum, cholecystokinin gets released, tells the pancreas, hey, we got food, we have to digest it. Let's go. Secretin stimulates large amounts of water and bicarb. Remember, we have to neutralize this acid. So where's all our bicarb? Mainly in our pancreatic juices. So secretin tells our pancreatic juices, hey, we need more. We need to neutralize this acidic chyme that's in our duodenum. We don't have the cells for it. That's why if you ever have heartburn or like you have a burning sensation or pain from like if you have certain types of ulcers, that's going to cause a lot of pain because of the acidity. And the secretion is in three phases. What does that mean? The cephalic phase. This is you smelling the food or knowing that you're going to eat, or you have your dog who once they hear the crinkling of the wrapper for their food, they know it's dinner time and they come running over. That's cephalic. They know they start salivating. That's the cephalic phase. The next is the gastric phase, meaning we actually have food now in the stomach, causing expansion of the stomach. Obviously, we know we have food in there. We have to digest it. Let's get our enzymes be released so we can start digesting and breaking down our food. The last one is the intestinal phase. What does that mean? Secretin stimulates release into the duodenum. Again, in this phase, we have chyme in the intestine now. It's acidic. We have to neutralize it. And that's where the bicarb in our pancreatic enzymes will neutralize that acid. So always think about it as if I'm digesting my food, what do I need to have happen? And these are things that are promoting either enzymes for breakdown of food, acid reduction with bicarb, or more enzyme release with obviously with cholecystokinin. So hopefully that helped with that question, Gabby. Okay, any last minute questions? Okay, well, thank you all very much for coming. Hopefully this helped. Good luck studying, and I will see you all in the morning. Good luck.